This one's working. Good morning, everyone. Hi, my name is Megan Miola, Commercialization Specialist, and I have the pleasure of introducing Dr. Shadi Arefich, who is presenting our next CE lesson, Like Breathing Through a Straw, Brachycephalic Airway Syndrome, sponsored by Zomedica. Dr. Shadi Arefich, DVM360, graduated from the State University of New York at Binghamton, where he received his Bachelor of Science degree in Biology in 2001, magna cum laude. He then attended Cornell University, where he received his Doctorate of Veterinary Medicine. After completing his studies at Cornell, Dr. Arefich participated in an intense one-year small animal medicine and surgery rotating internship at Angel Animal Medical Center in Boston, Massachusetts in 2007, followed by 2 rigorous one-year small animal surgical internships at Long Animal Veterinary Specialist in Plainview, New York. Dr. Arefich achieved his board certification in small animal surgery by completing a 3-year small animal surgery residency at LIVS and subsequently became a diplomat of the American College of Veterinary Surgeons. After opening for almost 10 years at LIVS, Dr. Arefich elected for warmer weather and transplanted to Las Vegas, Nevada in 2016. In Las Vegas, Dr. Arefich became a staff surgeon at a Las Vegas Veterinary Surgical or Specialty Center, In 2017, he began flying across the United States performing surgeries at a number of emergency and specialty hospitals in a need of surgical assistance. This was followed by a chief of surgery position at United Veterinary Specialty and Emergency in Silicon Valley, California. Managing their 3 locations, Dr. Arefich and his team successfully cared for dogs and cats in the Campbell, Mountain View, and San Jose areas. In 2018, he joined True Care for Pets in the Los Angeles, California area as chief of specialty, where he was instrumental in morphing the after-hours and weekend emergency hospitals to a successful 24/7 emergency and multi-specialty veterinary hospital. While the size of the hospitals tripled, he instituted hospital-wide protocols, managed the surgery, internal medicine, and oncology departments, and became a leading force on social media platforms. In 2020, he changed gears in his already illustrious career, finding a novel and state-of-the-art means of reaching concerned pet owners and their ill pets worldwide, Vet Triage. Dr. Arefich currently serves as their chief medical officer. Shadi has been published in scientific and medical journals and enjoys lecturing to a variety of audiences. He is known for being a positive force and energetic force, both professionally and personally. Dr. Shadi, everyone.
Thank you. Thank you, everybody. Thanks for coming by. Good morning. Thank you to Zomedica for sponsoring this talk. So hopefully, if you folks will find it useful. Brachycephalic obstructive airway syndrome. The proceedings are going to be updated later today, and I just updated with the most recent literature. So this talk is intended to be very practical, very clinical for you. The proceedings are going to be insanely detailed, like academic level. So if you want that kind of nuance, it'll be in the proceedings later on today. So you've already heard a little bit about me. This is our outline for the talk. We'll go through the definition of this pretty complex syndrome, but also very common syndrome, pathophys behind it, how gastrointestinal disease relates to it, clinical signs, a bunch of diagnostics, how to manage them medically, but of course surgically, and then monitoring for patients post-operatively, reported complications, outcomes, prognostic factors, and some final key points and any questions folks have. So this is a multifaceted disease. It has many levels to it. In fact, now they're calling the operations for this procedure multi-leveled operations because every pet has the interventions that are individualized for the patient. So this is just the most common components of this syndrome, and we're probably all familiar with these definitions: elongated soft palate, hypoplastic trachea, nasopharyngeal stenosis, stenotic nares, everted saccules, everted tonsils, laryngeal collapse. And we all know the breeds that get this syndrome. The pathophysiology for this is pretty interesting in that we believe it begins with the stenotic nares. That seems to be the start of this, and that of course increases the airway resistance downstream from there. And so dogs typically, if they're brachycephalic and they're born with this syndrome, the stenotic nares are their first steps, and early on that's the only clinical sign, abnormality that you find with them. But then as they get older meaning like 3-4 months and beyond, the palate, soft palate, ends up becoming longer, thicker. It adds to the turbulence of airflow that the stenotic nares already initiated, and then downstream from there, in the laryngeal region, the laryngeal saccules, if you can see here by that X, those two bubbles behind the arytenoids there, those saccules start to get everted, so do the tonsils and the tonsillar crypts. Over more time, laryngeal collapse becomes evident as the cartilages begin contacting each other, causing inflammation, edema, swelling, and then end stage, let's say advanced laryngeal collapse, you barely have an airway. And so that's the way this condition typically will progress. You don't really see it skip. It usually starts rostrally and then goes more caudal in the patient. And this is pretty striking when you look at a mid-sagittal CT of a brachycephalic dog skull compared to a normal dog skull. I mean, look at the anatomy, all the deformation. They barely have any airway to speak of in the nasopharyngeal region. So more and more recent studies are looking at the nasopharyngeal region in terms of these caudal aberrant turbinates, so abnormal turbinates in the nasal cavity that are adding to more of the resistance in the airway. And this is what a normal dog should look like, just plenty of openings in the nasopharyngeal region. And then look how extreme these dogs' skull morphology is, and that's where it begins. Obviously, these are all brachycephalics, different severities. And then over time, as you end up going through those stages of stenotic nares, palate, everted tonsils, everted saccules, these caudal abnormal turbinates are already there, and then they develop hypoplastic trachea over time, we think, as well as later on bronchiolar collapse, and then all the other pulmonary and cardiac changes from there. So some folks have been recently defining this as a systemic disease because it affects the body in such a way. GI disease is interesting because this is the same breed of dogs that also get their own set of GI diseases anyway. And so the question is the chicken and the egg scenario here. But examples include things like megaesophagus, sliding hiatal hernias, gastric dysmotility, pyloric stenosis. So the question is, who started what with these dogs? But we definitely see, especially if you investigate further in the history, usually these dogs have some kind of fluctuating chronic gastrointestinal condition associated with their breathing issues. Clinical signs, the typical raspy breathing, the snoring, the stridor. We all know what it sounds like, what it looks like. And typically radiographs for a lot of us will be the first steps in trying to diagnose the condition, because sometimes these pets show up in respiratory distress and you're trying to figure out, is this cardiac, is it respiratory? So the radiographs have different roles to play. For example, in this skull radiograph here, you can see the soft palate, and so sometimes in these dogs it's evident and it'll look abnormal and also be extending into the laryngeal region. This is an example of how we measure for hypoplastic trachea. So there's a ratio which will be in your notes on how to do this. I, for one, just typically eyeball it. If it looks like it's a narrow trachea, then I call it that. But if you want to be more objective about it, you can measure it. And then, of course, bronchopneumonia, right? The cranioventral distribution of pulmonary infiltrates, very common with the breed in general. Those that have the syndrome, those that have GI issues. So pneumonia is a big one. CT scan is typically, I don't typically perform CTs for these dogs. There are, in your proceedings, plenty of examples of folks using CT to try and objectify the condition, but the turbinates are the main thing you're looking for with a CT scan. You're looking for any kind of nasal septum deviation, the caudal abnormal turbinates in these dogs. You can see how their sinuses are obliterated because of their skull morphology. And then, of course, we have a grading system that categorizes these caudal aberrant nasal turbinates and the brachycephalics. Laryngoscopy is key. So typically these dogs are coming to your clinic, respiratory distress, they're cyanotic, they're hypoxemic. The sedated laryngeal exam is going to be the first step. The stenotic nares, you can tell, obviously, have got those. Radiographs are going to be collected at some point, pending patient safety. But this is going to be the big one, is laryngoscopy. You're looking for the elongated soft palate, you're looking for the saccules, the tonsils, and then any evidence of laryngeal collapse. So here's an example where the cartilages are contacting each other, and you can see everted saccules caudally. And then, of course, this is all just swollen edema. Here's a palate that's very long. It's past the epiglottis. And we grade laryngeal collapse in 3 stages. It first begins with everted saccules. Everted saccules, by the way, are very dynamic. So I've gone away from removing them surgically, but we'll talk about it. But saccules are simply a secondary change to the upper airway resistance that you're getting from stenotic nares, palate, etc. And then stage 2, the cuneiform processes of the larynx begin contacting each other. And then stage 3 involves both of these stages plus corniculate process contact. So this is an example of normal anatomy drawing there, but anyway, you grade them. And of course, the stage rather of these laryngeal collapse schemes are related to prognosis. Any questions, by the way, feel free, reach out, shout out, raise your hand, doesn't matter. Very open here. So then scoping, I as a surgeon don't perform any scopings, but I've worked these cases up with internal medicine specialists. We're looking for evidence of hypoplastic trachea, bronchiolar collapse, any abnormalities in the lower airway for these dogs, and that's the idea behind the scoping. So medical management. So this, of course, is a bit more complex. It's very nuanced, but essentially it's the same basic parameters, right? You're looking at anti-inflammatories, oxygen therapy, sedating the pets, and this picture just shows all the different forms of oxygenation that we have for these pets. Depends on what you have at your clinic, of course. I've had pet owners that have oxygen tanks either themselves or neighbors have them, and so they'll use that to stabilize the pet till they can go to the ER. So you just get creative with it, but all of these different oxygen modalities have pros and cons to them. Here's just a small sampling of medications that these pets may receive for trying to stabilize them. The end goal really is to capture the airway, stabilize the pet hemodynamically, cardiovascularly, and then once the patient is more stable, perhaps then perform the diagnostics that you need. Obviously, it's going to depend on the stability of the pet and what you have available at the hospital, as well as what the pet owner wants to do. The reason I mentioned here Convenia, I think it's a great example of antimicrobial coverage for pets that you're worried about gastrointestinal and respiratory issues that are having difficulty with taking oral medication. It's not the most broad spectrum drug, of course, we all know that, but it is something to consider. We've used it prophylactically in pets for brachycephalic disease that don't have overt pneumonia. But another good example of that is Simplicef. Again, not the most broad spectrum, but once a day administration, not too bad. And then Serenia, of course, has gained massive traction over the past decade for not just for anti-nausea, but as a pre-medication and other utilities. So that's pretty cool. And then finally, with metoclopramide, I like to use these in pets that you can tell on radiographs they just ate a meal and now have to undergo emergency airway surgery. So I'll use Reglan to help move the food along in their GI tract. And for pets that are prone to regurg in general, or if they're regurgitating under anesthesia or postoperatively, I'll either give them boluses of metoclopramide or just put them on a continuous rate infusion of Reglan to help with GI motility. Because pneumonia is a big problem, right, for these dogs. For prognosis, with anesthesia and surgery, it's a big issue. And then I just want to have a reminder about tracheostomies, both temporary and permanent. There are more studies now looking at placing temporary tracheostomy tubes to help stabilize those dogs that come to your clinic in severe respiratory distress. It's a nice way of bypassing the upper airway. It may seem scary at first, and I encourage, if you're going to dive into this world, start with cadavers and make sure you're comfortable with the anatomy. You need specific supplies for it, and then of course there's a whole bunch of maintenance afterwards. But if you're talking about trying to stabilize a pet in preparation for surgery, a temporary tracheostomy can work pretty well. So now with surgery, how many folks here perform brachycephalic surgery at their clinic? Yeah, a lot. How many folks perform it without any respiratory signs other than like the snoring and stuff? Like you just fix the nares, maybe the palate. Yeah. And how many folks will operate these dogs under a year of age? Yeah, okay, yeah, a few people will. Because that's always the question that we get here, how early do you cut them? And the literature will say something like, if they start hitting 3 to 4 months of age, that's when you start seeing the more severe sequela to it, and that's pretty young. You can, of course, try and combine it with a spay or neuter or a dental or something like that if the patient is not in an emergency situation, but it is still an area of investigation for when it's optimal to cut these dogs. But in general, we do believe that early intervention is better for them. So surgery, the typical surgery setup when you're working in the external structures here, like the nares, for example, the dogs are in sternal recumbency. You're usually trying to position their heads and their oral cavity in some permutation of IV poles and gauze to position it for the surgeon, and then you go for it. The nasal surgery, there are so many different techniques for this procedure, and I'm sure folks here who perform this surgery have their own variations and what have you. And to me, with this surgery, it's more of an art than a science, because obviously you want to make it symmetric and cosmetic. Even though the dog may not care, the pet owner will care, and you also want to make sure that you actually achieve what you're trying to achieve. So here's a before and after photo of the nares, and I tend to find I work on the right side first, then I do the left side, and I realize, oh, I hate the right side now, so then I'll go back and do the right side. I always end up having to go back and forth to make them more symmetric. So typically you start with the patient intubated, repair the nares, and then place them in this position, open their mouth to work on the palate. You'll have to move the endotracheal tube out of the way, or you could also temporarily extubate them if you're pretty fast with palate resection, but that will be the next step typically, is palate resection. And again, just like stenotic nares, there's a ton of different techniques for this. I'm a huge fan of using a bipolar vessel sealing device like ligature. I think it's great. But there is the cost of it having extensive thermal injury to the tissues versus something like a CO2 laser that does not have that much thermal, but it's super fast, whereas other techniques might be a bit slower. I was trained initially with this back in the day before this was even a thing yet, and it just takes forever. And it can be a problem with hemorrhage, especially if you're not that experienced with it. But anyway, the sharp technique, cut and sew technique, it was the most common, but now we have a bunch of fancy tools we can use to try and decrease the surgical time, anesthetic time, the postoperative hemorrhage, swelling, edema. And the key points I'll make with the palate is keep in mind too, because the patient again might be intubated, probably, and someone is holding the mouth open or it's propped open, someone's holding the tongue away. All that manipulation alters where the palate lives in that dog, and it's going to affect how you cut that dog. So you want the elongated soft palate to be as a natural position as possible when you decide to plan your cut. And of course, the most natural position is extubated in the dog's mouth pretty closed, but that may not be the most realistic. So I find myself constantly moving the trach tube, moving their tongue, opening, closing the mouth before I decide where I'm going to make the cut, because you can definitely miss the mark of where you're trying to actually make your cut for the palate. So keep that in mind too. As you manipulate the skull and the mouth, it's going to manipulate positioning of the palate. So take your time in planning it. And like I said, if it's really a close quarters where you can barely examine the palate with the endotracheal tube in place, then temporarily extubate them. Have propofol or something ready in case the patient starts to wake up, but it's this dance that you're trying to play with, figuring out the appropriate way to cut these dogs, and this seems to be too short to me, by the way. I mean, the goal is to have it where it just about reaches the very tip of the epiglottis. This seems really short. I don't know if that was intentional or not, but anyway, it's just a drawing. So then, once the palate is resected, you can now visualize the laryngeal opening a bit more because the palate is no longer obstructing your view. You can visualize the saccules, and like I said, I've come away from removing these, but you can. I'm not really convinced based on the literature that it really has any post-operative benefit to these dogs. And because it's dynamic, if you repair the stenotic nares and the palate, then hopefully the tonsils or the laryngeal saccules will recess. Yes, question.
The age at which you do that play into that decision to remove the saccules if it's like an older dog?
Mm-hmm. Yeah, so the question is, do you consider everted saccules, removing them or not, based on the age of the patient? And the answer is maybe. So what I've been doing lately is, after I repair the nares and the palate, I will evaluate the saccules throughout the surgery and decide whether or not they're still prominent. That's not, of course, not the most realistic way because they're under anesthesia. But if I'm not convinced they are consistently everted during the entire procedure, then I'm leaving them alone. You could always go back in if you had to. If the patient has significant sternum or whatever it was post-op, despite repairing the nares and the palate, you could always consider resedating and then say, okay, maybe I have to remove the saccules. The patient is still clinical. I haven't had to do that yet, and I'm convinced because these saccules go away. But I would say in the patients that I have removed the saccules, the older ones are most commonly the ones that I'm doing it on. But that's also lessened over my years. Yes?
With the ligature clamp that you showed, it's sort of small, that one.
Mm.
Is that the one you're using for bulldogs?
Yeah, so
How many cuts across do you make?
So the question is this ligature device what I'm using for bulldogs, and how many cuts across? So excellent, because this ligature has to be small in order to fit in these oral cavities. They have small oral cavities, these dogs, despite their huge skulls. And there's not a lot of room in there to work with. And you're trying to retract the palate with Alice tissue forceps while fitting this ligature in there, while probably an endotracheal tube present. And so you have all these factors you're trying to balance. So these have to be small in order to fit in the mouth. However, some of these palates, as you folks who operate these dogs know, are very, very thick, especially English bulldogs. So it's not always an option for them. And if I can't fit a bigger one in their mouth, then I'm going to end up doing it the old school way. So it depends on the size of the palate, but unfortunately that is a limiting factor with techniques like this. As far as how many cuts or how many times do I go through, 3 typically is enough. The answer is as many as you need, because theoretically, if this is going well, as you cauterize and cut, you're not getting hemorrhage on the cut portions. Whereas here, if you're trying to sew and cut at the same time to try and minimize hemorrhage, and you slip up or there's a gap or something, then you can have hemorrhage during the procedure. But typically 3 times is what I find. I have had unfortunate scenarios where the tips of the ligature contacts the palatopharyngeal arch, so you'll get thermal necrosis outside of the palate, which is unfortunate. Doesn't seem to cause a problem with the patient, but you don't want to do that if you can avoid it. And that's because of the small corridors that you're working in.
Do you go straight across, or you come from each side and then do the middle?
So I go straight across. So because I'm right-handed, so I'll go right to left. Do you do it differently, or
No, well, I've done it both ways and
Yeah.
tried the different size clamps. I use that and I like it, but sometimes I worry about doing it too many times. And like some of these bulldogs with these big thick palates,
Yeah.
I'm doing 4 or 5 times, and then I worry about how much thermoelectric burn there is.
Yeah, and that's the biggest problem with this technique is the thermal necrosis associated with it, and that's been shown on histopathology in the papers. Those will be in your proceedings as well. But yeah, it's a big problem for those thick palates. I end up having to convert over to standard procedure. I have had situations where, because again, I always go right to left, where it looks crooked, you know, and I have to now go on one side and kind of trim a bit more. And it's annoying to trim with this thing because it's not that fine. These are thick jaws. And so to try and trim some more is a bit difficult, but it can be done. It can be frustrating. But it requires time over time, just getting better at it.
About where is the palate relative to the tonsils where you're cutting?
Oh,
So the edge of the palate and the tonsils, because I'm kind of looking
yeah. So
halfway up the tonsils.
So as far as either tonsils go, I've never seen them. So my reports of tonsils being everted are purely from the literature. Everted saccules I see fairly often, and they should be behind the arytenoid glottis. The normal palate should end just about the tip of the epiglottis. Obviously, if it's elongated, it's going to be anywhere in this vicinity. But a lot of times I can't see the everted saccules unless I remove the palate first. Just depends on the size of the oral cavity for that pet. Does that answer your question?
Well, I guess I was asking, you know, when you're doing this procedure, you can see the tonsils there. You know, they're elongated. I was sort of trying to make the palate edge where I thought it needed to be, and it's usually like halfway up the tonsils, maybe a little less.
Oh, I see what you're saying. So you're saying you're using the tonsils as a landmark for how to make your cut.
Yeah.
Yeah, fair enough. I'm always aiming for just about the tip of the epiglottis. Yeah, and the reason for that is because my main fear with these pets, thankfully, knock on wood, hasn't happened yet, is nasal regurg from cutting it too short. So I'm as long as I feel as though my planned cut is going to cover the epiglottis sufficiently, that's what I aim for. Any other questions? Okay, and then we have just some ideas here because we don't really have a good method to try and treat hypoplastic trachea in these dogs. Based on my own experience and the literature, there's not much yet to be done. I have had cases where surgeons have placed tracheal stents in hypoplastic tracheas. The problem with the stents, of course, is that hypoplastic tracheas are an innately small tube. They're not dynamic like collapsing trachea typically is, and so how much benefit there is, I don't know. Now, if you're talking about life and death, meaning you've already stabilized the pet, you've operated with what's operatable, and they're still in severe respiratory compromise, you believe the lower airway is the problem, then I suppose for a Hail Mary, it's an option. I'm not advocating for this. There's no studies on it that I know of, but just something to think about as far as thinking outside the box. Same thing goes for laryngeal collapse. We don't really have a good solution for laryngeal collapse. The best solution for it is prevention, and that's by cutting these dogs early. But anyway, so like arytenoid lateralization, like you would do with a tieback for laryngeal paralysis, may be an option for some pets. Arytenoidectomy is an option, but none of them are great options because either way, the whole structure of the larynx is deformed. So then monitoring post-op. We're all familiar with manual monitoring, which is very subjective. We use the tools at hand to figure out how these pets are doing. But lately, over the past few years, we are developing more and more devices. And we on the veterinary side are really behind the human side in terms of telediagnostics. Those diagnostics that can give you information about the patient, objective information in a remote manner. And so something like VetGuardian, I advocate for. These types of devices can measure multiple parameters, and this one is quite extensive in terms of what it can monitor. This is great for those patients that you can't manipulate, because every time you manipulate them, they get stressed out and go into a respiratory crisis. Or in those pets that are receiving oxygen therapy, like an oxygen cage, and every time you open that damn door, you're releasing that oxygen, and it ruins the point of that. But yet you want to monitor these patients. You want to get their respiratory rate, their pulse ox, heart rate, blood pressures, whatever. And so devices like this help at least take care of some of those measurements without having to continuously manipulate the pet. And so you'll have an iPad in your hospital with the VetGuardian looking at the pet. You can have multiple pets here on the same monitoring tool, and it's thermographic based to try and collect these parameters. Let's see here. This is what the VetGuardian looks like. as an example of a telediagnostic tool. There it is. You figure out a way to attach it to the cage. It's pointing right at the patient, and it has benefits to relieving your staff so they can focus on other critical patients. The pets, of course, benefit from it. Clients are going to appreciate this type of thing. The practice and telediagnostics are the future, and we're just starting to dabble in this world in the veterinary field. And this is how this product works. So here's a close-up view. Very cool, nice clean interface. Monitor multiple patients. It's really awesome. Any device can hook up to it.
I have a question.
Yes?
For that. So as cool as that is, it just makes me nervous because, for example, like using a pulse ox, good grade 99% not attached to anything, and with all the interference and the patient moving, like you're not. Is this accurate? Pretty accurate, or
Yeah, that's,
something worked on?
yeah, so the question is how accurate is this? Because you're going to have factors that relate to the machine, you're going to have factors related to the patient. And so my answer always is to that kind of question is you have to use multiple parameters, right? So if you are in a hospital that you think, oh man, this might benefit some of my patients, then I encourage you to use it on patients that are a bit more stable and just see if you believe the parameters that it's measuring. And then go from there to more unstable patients. At the end of the day, it's hard to replace a human being, and you know, nothing is going to replace the intuition that you as veterinarians have or licensed veterinary technicians have. So devices like this are trying as best they can to give you objective measurements while also minimizing contact with the patient for whatever reason, whether it's stress-related or infectious or oxygen therapy, whatever it is. So yeah, you have to be able to use your own instincts on it and see whether or not you trust it. But from what I know about it, it's been pretty good so far, and I'm dabbling with the idea of using these for my hemoabdomens, like post-op splenectomies too, to see if they work. Right now, purely my only experience with it is for respiratory cases. That's what I've focused on. But it seems pretty good so far. Yeah. And a huge benefit to these things really is relieving the staff. Now, again, you're not supposed to just close your eyes and walk away, but we all know how some of the ICUs can get. And if you're a facility that has emergency cases and critical patients, then it can be very stressful for the staff to monitor these patients. Yes?
Does it work through a plexiglass door?
Mm-hmm.
And then does it take like the temperature of the cage inside into account?
Yeah, so the question is, does it work through plexiglass door, and does it take into account the temperature of the cage? So because it's thermography based, from what I've seen, the plexiglass door doesn't affect it. It's purely focusing on the patient. I try to avoid things like this pad, this clipboard in front of the view. I haven't played around to see if it actually causes a problem with the thermography, so I wouldn't do this. I would make sure that the cage is open as possible, but I haven't seen it been a problem through a plexiglass.
I have another question.
Yes, question.
Well, two questions.
Mm-hmm.
So I'm guessing it works even when the patient's moving around.
Mm-hmm. Mm-hmm.
It'll still read.
Yes, the question is, does it still read if the patient's moving around? Yes, it does.
Okay. And two, I guess, would there be interference if you use it for MRI from a bar?
So another question is, would there be any interference if you use it with an MRI? I don't know. I've only used it up close and personal with patients in ICU. I have not used it for monitoring during MRI or CT or anything like that. And I can't actually tell you if it's MRI compatible or not. I haven't looked into that. So I will find out that part for it. But yeah, no, I haven't used it for telediagnostic monitoring outside of cage side, pretty much. Yeah. All right. Let's see. Okay. Complications with surgery. Pneumonia is a big one, of course. Bronchopneumonia. Sometimes these patients are presenting with pneumonia. Some develop it post-operatively. So that's our biggest issue. I always have kind of difficulty with aspiration pneumonia, because the word aspiration means something. It implies an etiology. And so I tend to call it bronchopneumonia, and it could be for whatever reason, whether it's regurgitation related, like aspiration related, or hematogenous or something like that. So just be careful with the words that we use. I don't call every single pneumonia aspiration pneumonia. If there's a reason to call it that, like the patient has a history of vomiting or regurgitation, then I'll say suspected aspiration, but it's just be careful with the words that we use. The other complication, of course, is laryngeal collapse. Not really a fault of the surgeon, obviously. It's just something that can't really be dealt with. This is a very severe one, but that's also a reported issue. And then anything related to tracheostomy placement, whether temporary or permanent, these are huge, these require a lot of husbandry after placing them. Outcome overall, 85 to 100% improvement. Mortality is a pretty wide range, but generally other papers report 4%, 5%. It just depends on what you read, how they're measuring these. Recovery, 6 months post-op are considered excellent in 65% of patients, good in 25%, a year out, excellent, 50%, moderate, 48%. And then with GI disease, once you repair the respiratory component, you'll see improvement to resolution in 66 to 91% of patients. Owners that are aware that you treated both respiratory and GI report higher success rates or higher satisfaction with their dogs when both body systems are treated versus those where only the respiratory tract is treated. So 68% owner satisfaction with just treating respiratory, treating both GI and respiratory, 89% satisfaction. This is just a short list of prognostic factors that are going to be in your proceedings. Early surgery, we all are in agreement that the earlier you can cut these dogs, probably the better, and the literature shows that as well. There are some recent papers that say that being younger actually is a negative prognostic indicator, although I'm not as convinced still, because there are other papers that show younger is better, and if you're performing early surgery, they're going to be younger, so I'm not sure. We'll have to see. We need larger studies, we need prospective studies to verify what the trends truly are. We all now know laryngeal collapse is a problem for these dogs. Hypoplastic trachea is a negative prognostic indicator, the presence of pneumonia. Any other concurrent airway pathology, so lower airway stuff like bronchiolar collapse. The GI disease, the presence of GI disease does affect prognosis, obviously, right, because we do see more bronchopneumonia with cases of regurgitation and vomiting. And then a recent paper found that when you perform multi-level surgery, traditional multi-level surgery, complications go up. A lot of, and again, what you mean by traditional was hard to say in that paper, but I imagine things like harmonic scalpel or CO2 laser are considered maybe less traditional. Maybe they're a bit on the newer side. I don't know, but we'll have to see as more studies come about as to, do you see more complications with dogs that are operated on multiple levels? Obviously, it's intuitive to think that probably if you're repairing more than one thing on a patient, that's more anesthesia, more surgery, more morbidity, and so it would make sense that more surgery is going to be more detrimental, but also that's what that pet needs. So we'll see as more and more studies come out on this. Final thing here is some key points. Client communication is key. You want to talk to the clients about your suspicion, what diagnostics are needed, that this can go up the chain of diagnostics, which of course usually means finances too. They have to understand that the complications of this surgery, a lot of times you may not even know it until after you've done your sedated laryngeal exam to see the laryngeal collapse, right? Or maybe they had subclinical pneumonia that became full-blown pneumonia a day or two later. So client communication is key. And what I typically tell clients when I'm presenting this complex syndrome to them is I actually divide these conditions into repairable and non-repairable. There are some things a surgeon can fix, there are some things we can't fix. Your dog may have one or both of those categories. So things like nares, we can fix that. Palate, we can fix it. The saccules. Hypoplastic trachea, we can. Laryngeal collapse, not really. So I make sure they understand that there are some things that are in our control, other things are not. Keep in mind gastrointestinal signs, dive into the history, see if they ever have a history of GI issues, and make sure to tackle those as well. And then you want to tailor the surgical repair to the case at hand. Not every palate needs to be resected, right? Not every saccule needs to be removed. So it depends on the patient, make sure to tailor it to the patient. If you have any questions, these are all of my social media, my email. Thank you again to Zomedica for sponsoring this. This is the QR code for vet triage, if you guys are interested in learning more about that. I'll take any other questions you guys have. Yes?
Sorry, so a couple times you referenced laryngeal collapse.
Mm-hmm.
And I know the laryngeal process, but the difference visually, is that once you trim back the actual soft palate, you're gonna be able to see that, like, that looks edematous to me. I guess I don't know what laryngeal collapse looks like.
Yeah, so I'll go back to this drawing. Laryngeal collapse is going to be dynamic. It's also going to be, well, it's dynamic, but in terms of it changes with respirations, but it's going to progress in the patients that already have it. Where is that drawing? There we go. Okay. So this is a normal larynx, a normal laryngeal opening. Laryngeal collapse implies any deformation that's obliterating this laryngeal opening. So typically it'll start off with the saccules that are becoming everted because of the increased airway pressure. That's considered a grade 1. And then grade 2, you have the cuneiform, you have the saccules plus cuneiform process. That's this portion of the larynx here, see on both sides. So they start to collapse inwards. They start to meet in the middle. And then stage 3 are stage 1 plus 2. And then the corniculate process now starts to collapse, so the dorsal portion of it.
So laryngeal collapse is all of those stages?
Yes.
Stage 3, essentially?
Yeah, we recognize three stages of them.
Got it.
Yeah.
Got it. Okay.
And so as they worsen, they go up in stage.
I got you.
Another question? Yes?
What sort of expectations do you set with the client for breathing noises post-op?
Oh, great. So the question is, how do you set that client's expectations up for breathing noises post-op? I tell them I don't know what it's going to sound like. I said the goal with the procedure is multifocal. We're trying to eliminate the snoring and stutter and all that stuff. We're trying to prevent laryngeal collapse from forming if it's not already there. We're trying to prevent lower airway disease or coral pulmonale if it's not already there. And that's the goal. We may achieve all those goals, some of those goals, we don't really know. And so I tell them it depends. You hope that they're going to be silent. And I've had plenty of dogs that come in for a recheck 2 weeks post-op, can't hear a thing. Phenomenal. I have others that still are kind of a little bit on the gurgly side. So I warn them that I have no control over what's going to happen there. I tell them these are our goals. We'll see how many we attain. Yeah, good question. Yes?
I had a question about, and I'm sure, I think I kind of know the answer because I'm worried about the thermal necrosis, but what about using electrocautery?
Oh.
Procedures, if you have a bleed or like whatever, or even using it to cut?
So the question is, what about electrocautery when performing these procedures? I'm going to assume you mean for the palate resection.
Yeah, the palate resection.
Yeah. So I've never used electrocautery because the tip of the cautery is so narrow, it's so fine, and these palates are usually so thick. The other thing is too, for cautery, typically you want to have an area that you're targeting for hemostasis, whereas when these things bleed to me, I can't tell where the heck it's bleeding from. And so I'm trying to either cauterize the whole thing using like a ligature device, or I'm sewing them basically blindly to try and stop with the bleeding, and then once it's under control, reassess and go from there. So I have not used electrocautery for these. Has anybody here used electrocautery for palate resection? Yeah, it just doesn't have.
Sure, but I didn't know if there was subduction, but I know if there was another alternative.
No, not that I know of, and I haven't seen any literature on that either. One thing I will say, sort of in line with that, is what I do after surgery while they're being recovered is I will actually take an ice cube, I'll wrap it in gauze and attach alopecia forceps to the gauze, and I'll have the ice cube sit on the palate edge. And the technician, of course, is monitoring the patient, obviously, to make sure they don't swallow the thing. But I find that ice cube for no more than 10 minutes. I think, again, I haven't done any objective studies on this. I think I see less postoperative edema, difficulties breathing if I cool compress the surgical site. So that helps anybody. That's worked for me.
Are you
Yes.
doing that while they're still intubated, the cold compress?
Oh, so the question is, when you do the ice cube technique, are they still intubated? Yeah, because I only want it in there for 10 minutes. So I typically have the technician, when they have the dog on the floor on the recovery mat, they've got the ice cube in there, and they're waiting for the dog to be extubated. Obviously, if the dog gets extubated before 10 minutes are up, that's fine. I don't care. But yeah, typically they're in the recovery mat, just waiting to be woken up, and then 10 minutes passes by pretty quick. Yes.
We usually do a pre-op NSAID, but sometimes for these palate guys, especially if there's a lot of strugglers, right, we'll hold off on that in case we need to do post-op decks. Do you have any preference?
So the question is for non-steroidal anti-inflammatories. You'll use it for pre-op. However, sometimes they hold off on it because they may use steroids post-op. I'm in the steroid camp. I'm more, so my thought is, if the dog goes into a crisis post-op, steroids are going to be one of my go-tos to decrease that swelling. And especially if I've already done the laryngeal exam and I see they have horrible laryngeal collapse and edema and whatever else. So I tend to hold off on it. The other thing to make sure you're aware of course, is the history of gastrointestinal disease. If there's any evidence at all that you're worried this dog has active GI something, then holding off on anti-inflammatories is also beneficial. But again, the goal for these dogs that are really critical is saving their life. So what do I care if I end up developing a GI ulcer? They're alive, because they would have died otherwise. So do what you have to do to save the dog's life, but that's my thought process. I tend to wait for, see if I need steroids or not. Yeah. Yes?
So you wouldn't just have DexSP or Dex as your part of your pre-med, you would wait and see what would happen before you do it?
So the question is, would you use DexSP as part of, dexamethasone SP as part of your pre-med, or would you wait until they need it? So I hate to say it, both. So if I perform the laryngeal exam and I'm getting ready for surgery and I see that there are a ton of laryngeal edema, laryngeal collapse, then I give it as a pre-med. If I don't really see that, then I'm going to hold off until post-op to see if they have any complications afterwards. These dogs are typically going home like the next day, rarely the same day, usually the next day. And so I have those 24 hours to monitor the patient. Of course, I'm operating in the ICU, so there's 24-hour monitoring for the patient. So we have the opportunity to administer those kinds of drugs if our crisis arises. Yeah, great question. But I don't always pre-med them with DexSP. It depends on the scenario. And my preference, of course, would be an ideal word just to use NSAIDs, but they're just, to me, they're not as potent for anti-inflammatory in the crisis situation like steroids are. Yes?
For relatively stable planned surgeries, do you have a preoperative fasting protocol?
So the question is, for routine procedures, ones that you're scheduling, do you have a fasting protocol? Nothing different than any other patient, so no food after midnight, or no food after midnight the night before. Water is okay. That's where I go with it. Now, there is, of course, some concern if you fast them for too long that you'll end up getting the bilious vomiting and esophagitis, esophageal reflux. So, more than 8 to 12 hours of fasting probably isn't good for any patient. But, and of course, that could be the case if they already fasted all night long at home and you don't get to the surgery till noon. Yeah, they've been fasted for a while now. So it may not be as ideal, but otherwise, no. It's the same rules for everybody. I just fast them after midnight the night before at home. Yeah, and then for post-op feedings, I want to make sure, of course, their gastrointestinal signs aren't there, and then we start off with meatballs, hand-fed meatballs for the dogs, and see how they tolerate that before letting them have at it. With regular feedings. I tend to feed these dogs the same way I do like a laryngeal laryngeal paralysis or a post-op tie-back. Meatballs. I try to avoid anything that's going to create particulate matter. So dry kibble, for example, when they bite down, creates this dust. Theoretically, maybe that dust can settle down the lower airway, predispose them to pneumonia. So I tend to stick to canned food, hand-fed meatballs. The owner does it at home once the patient is discharged, and then work my way up to whatever their normal diet was. And then I do advocate for elevated feedings. Again, this is me doing this for brachycephalics. For laryngeal cases, like laryngeal paralysis, I think that's pretty much safe to say you want to elevate their feedings. But for elevated meaning like sternal level, just not on the floor. I don't mean like on a countertop. Well, I guess you could, but I don't care. But for brachycephalics, I also do the same thing. I tend to have them elevate the food. Yes?
If you're doing surgery on the upper airway and the dog has a sliding hiatal hernia at the same time, are you fixing that, or are you waiting to see if it goes away?
So the question is, if you diagnose sliding hiatal hernia, do you fix that at the same time, or do you wait for it to go away? I wait for it to go away. Yeah, if I can avoid doing anything like that, especially if there's a chance that secondary changes like sliding hiatal hernias will resolve on its own, I'm gonna choose less intervention. I can always go back in. If I need to reoperate for some other reason later on, whether it's that or something else, I can always go back in. There was one study that looked at the risk of anesthetic complications in dogs, in brachycephalics that have already been repaired, and the conclusion was, for the most part, they are safe for further anesthetic episodes in the future. Obviously, any patient can have issues with anesthesia, of course, but I'm gonna wait and see how they do. I also will say that sliding hiatal hernias are really annoying to diagnose, right? Without fluoroscopy, it can be very frustrating. So a lot of times I suspect it and I can't prove it, and I'll medically manage them perioperatively, but especially postoperatively. A lot of these dogs are going home with like omeprazole, for me, if they have a history of GI issues, or I'm just worried about because they had GI complications in the hospital or whatever. But I don't repair their hiatal hernias unless it's an issue after the fact. Any other questions? Great, thank you so much for all the questions. Thanks for attending. Enjoy the rest of the conference. Thank you. Sir, how are you?
I'm good, but gotta get you.
Sure. How you doing, man?
And they got me doing everything. They're like, hey, Walter, can you do photography and speak?
I didn't realize this is what you do.
Just when I got burned out and was about to leave VetMed, I was like, I'm going to do some videography. And I was like,
When I ended up leaving the Las Vegas practice, I looked into like being like a biology teacher in high school.
Dude, you
I looked
know
into
what
I'm like anything. I still want to be science, but I'm so sick of this.
I need something, and that was the thing about it. And then, and that's why I, tell people, they're like, dude, how did you get social media? I'm like, dude, sometimes those dramatic or traumatic experiences that maybe like you want to get burned out, don't leave. Take a little break.
Yeah.
Stuff
Yeah.
out, figure out what you love.
Yeah.
And you never know how that'll snowball into the other parts of it. So, like, going to film school, I learned cameras, I learned social media, boom.
Yeah.
And you just put it all together. So it was just one of them deals where you just grab your love. But man, you should go teach at a biology. You need to.
No, they wouldn't let me.
Why not?
You have to have I think a master's degree, and also have had like formal like teaching training.
Don't mind that you're a whole veterinarian.
I know, like what the hell? I felt like I was being like a douchebag. I'm like, come on guys, I'm a doctor. You can't let me in.
And some extra years on that. Yeah, they're like, nah.
Nope,
no.
not good enough. You have to go back to school and learn some more.
Awesome. I'll see you later on today.
Thank you very much. Yes, I'll see you later.
They really wouldn't let you educate.
Yeah, they said you had to have a master's or maybe even a PhD, but a master's was like the bare minimum, and you had to have formal like accreditation or some sort of training. And I thought, I get it, but that's weird. Like, don't you, like, if an MD wanted to teach biology in high school, they wouldn't be allowed to just do it?
Yeah, that seems
It seemed
insane.
weird. It seemed weird to me. But I that's okay. I ended up not doing that, of course, and then I ended up finding vet triage, and that was the whole thing.
I know, I didn't know that you were a founder, but I feel terrible.
Yeah.
I was reading, I was like, that's insane.
Yeah.
That's amazing.
We're so behind in this profession with telehealth. We're so stupidly behind. It's embarrassing compared to the human side.
Yeah.
We're 20 years behind
Easily.
it. They're doing
Yeah.
cool stuff, man, and we're still stuck on like VCPR. Get the hell out of here, guys! Come on. It's I can go.
You're like, I digress. No, your talk was fantastic.
Thank you.
It was really great to hear you talk, and I'm always some of these talks, I'm like, oh, it's just gonna go over my head. I thought you did a fantastic.
Oh, thank you very much.
Yeah, it's very palatable even
Thank you.
for me, so. So I did talk to Nicole. She said just email it to Adam.
Okay.
And he'll
He'll disperse it. Okay.
Exactly, yeah.
Do you know the MRI question that she had about the device? You know if
That-
it was
no,
MRI?
I heard
I've never
that.
had anybody ask me that before.
No, I've not either.
Good question.
Yeah. The questions were killer. I'm just like, what is all this?
And I liked the splenectomy you mentioned, because my boss had just done like 3 splenectomies, and I was like, oh, that would have been nice.
Yeah,
you know?
yeah. They're great. That's
You know how that goes.
Yeah, yeah. That's literally like Zomedica wants me to talk about hemoabdomens, and I'm like, can I incorporate this device into hemoabdomen care? Because it makes sense why you could, and it works on larger dogs. So I don't know, but yeah, I want to investigate that and see. Yeah.
Yeah, no, I'm gonna talk to a couple of my colleagues and see if they. I mean, it's a very unique question. Obviously not a lot of hospitals.
Yeah.
So no, I'm gonna see if I can get an answer.
Sure.
To that for
Thank you.
as well.
Thank you.
Yeah. Can I get you anything?
No, you'd be great. Thank you so much. Thank you for all this.
Yeah, no problem.
Yeah.
It was great meeting you formally.
Yeah, you too.
We'll see you around.
You got it.
Question for you, Chad.
Yes.
So after like begging and begging, my practice finally got the Legashire set up because I've been borrowing from my husband's practice. So finally they got the 3 pieces with me. a really big one, a long one, and there's a little one, and then there's that one. But there's one that literally looks like a mosquito hemostat when you hold it, and then when you let go, it just lets go. And so one of my colleagues used that with the palate. You know what
Okay.
I'm talking about?
No.
So I'll use it in like a spay.
Yeah.
Like a cat spay. It'll like, zzz, and when you let go, it just lets go.
But what cuts? Or
It
just-
seals too. Like it cuts and seals too. But it's
Okay,
like as soon as you do it,
Okay.
it cuts and it lets
Okay.
go.
Yeah.
So do you ever use that little one, or
I-
do you only use the plastic one?
I've only used the plastic one.
The plastic
I
one.
have used the one that they
It's
supposed to
called
use.
the FIS Act.
The one that you're talking about?
I think
Yeah.
so.
I haven't used that one.
Or it's just the plastic, that
Yeah,
one.
I've just-
That one handle, yeah.
Yes, that's the only one I've used, and so let's say like I'm cauterizing it. I like that I'm in control of cutting it because
Yes.
sometimes I'll cauterize more than once just to make sure, and then I'll cut once I'm sure. And if I see I have like 2 burnt edges, I'm gonna cut right in between them. You know?
Okay, yeah, cause you can.
Yeah.
And then move.
Yes.
And then cut.
But I've also used the ones for laparoscopy where it's a really
Yes.
long one with a tiny. But
That's my splenectomy friend.
oh, it's I use it for gallbladders for cholecystectomies. It's great.
Really not just they held it back for a long time, but now we have them.
Nice.
That's good.
You should charge for it. I mean,
We
you can't. Yeah, you make that money back.
You
It's.
don't have to tell me. You don't have to tell me.
You know, I've done latest shirt on new.
It's
on,
there. We had to be bought by NVA, and it was the first
Oh,
thing they got me, so
got
it's
you.
fine.
Oh, okay.
But that's good. When you do the palate, do you put one suture at the tip of the thing to pull it back?
Yeah.
Or do you grab it with the Alice?
It depends. So sometimes the Alice tissue force, I can't even grab the palate because it's so freaking thick, like those English
So, but you
bulldogs.
just put like one
Put a stay
in.
suture in there. Yeah. I try to aim it where that stay suture is going to be with the palate that I'm going to remove.
Right, right. One of my colleagues, he's really good. Before he intubates, he just watches it breathe. And he takes a Sharpie, wherever it is, touches it.
Oh yeah, yeah.
So he watches it before he intubates, and then he knows exactly like where is it touching.
Yeah.
So then he touches it with the Sharpie.
Oh, well,
So that then when he intubates, he remembers that's the spot that he wanted.
oh, that's cool. See, I've done that at the beginning with cautery. I'll do like monopolar cautery. I'll just zap it and.
Sharpie
but
marker.
Sharpie, that's
where
smart.
The GP's, friend.
I love that.
And I do that with my nares too, because I want them to be
You
symmetrical.
you draw
my
really.
triangles with a blue Sharpie
I'm gonna
with a
put
black
that, I'm gonna
nose.
put that in
Okay,
the
blue
top.
Sharpie
Yeah.
on a black nose. I make my triangles so that
Yeah.
I can know before I take out my 11 blade.
I'll put it in here.
Okay.
I love it. Thank you. Good seeing you.
Poor person's tricks here.
I love it.
You ready?
Yes.
Sorry to continue to hold you up here.
Oh, no, fine,
I was
fine.
just wondering, so I had a bunch of Frenchies come in recently and, I found, just stumbling through it myself, that if I had them give like a quarter tablet of, we have a compounded gabitrazone tablet,
Mhm.
and it's like 300 milligrams of gabapentin and 150 milligrams of trazodone, yeah, and it's a marshmallow sport thing, and so if they give a quarter of that, because they kept coming in and they get stressed and then they start puking, and then I had, and some of them are intact, some are not, and I'm just like, just in an effort to try to like stabilize them, giving them like ondansetron and Serenia and having them come in on some of that. I think mostly the Serenia maybe, and the gabitrazone.
Mhm. Oh yeah.
Such
You
a better
have-
experience.
They give it in the morning before showing
So
up.
I have them do like a quarter tab the night before the appointment, like before bed, and then, or like in the evening, and then another quarter tablet in the morning, and then have that 3 hours before their appointment. If they're making an afternoon appointment, it can get a little bit tricky, but it needs at least 3 hours, I find, and then even though he was still intact, it was like a totally different experience. And then I had another one come in, another Frenchie, and they were trying to, she was, she vomited like so many times that blood came up, and I was like, oh my god, because that was the first I had ever seen that. Like, and I'm trying to like let them with a fan on their face and the ice packs and like them just cool down and try to like get them out as like quickly. But like the first one that the first French I mentioned, that one, the owner is trying. She had pumpkin pet insurance. She has the care credit. She went to Eclipse in Whitney, New Jersey, and tried and had the surgical consult there, and to get it taken care of. I forget how old this dog is right now. But it's the surgeon mentioned to her that looking at it, she thinks that it's based on maybe it was the conformation of the head and the how stenotic the nerves were, because there wasn't any sedated laryngeal exam done from what I could tell. But I guess that just the consult appointment, would you not normally do the sedated laryngeal exam during that
No.
versus the day of surgery to do it? Or
So it depends. So if the patient comes in respiratory distress, because one of your goals is going to be to capture the airway, so I'm doing my laryngeal exam anyway while I'm intubating them to save their life, right?
Yeah.
And so that's handled. If they're coming in with the concern of like, oh, he's
It's not
snoring a
in
lot,
distress, yeah,
right?
yeah.
Then typically I'll set them up for, I'm going to fix whatever I can fix, and it could be the nose, the palate, whatever, and then I diagnose it the day of surgery.
Oh, okay.
Yeah.
Okay, so that makes sense
Yeah.
then.
If I have a client who needs to know right now, maybe financially or something like that, then sure, yeah, I could. I'm trying to avoid multiple.
No,
multiple-
that makes more sense. So I'm sure that's probably what the surgeon intended to do then, is when they came back to do the surgery. But like, is there a certain cutoff point in a Frenchie, that age-wise, that, you know, let's say that they're genetically and their conformation is such that it's pretty advanced to start off with, you know, now this dog, like, does it matter 2 versus 4 versus, I mean, I think it was supposed to be done, 6 months or something?
Yeah.
It sounds like that's what I'm hearing, I don't know.
6 months seems to be what most people land on. The literature goes 3 to 4 months.
Right.
But 6 months seems like what.
Well, we're past that at this point, I think it's 2.
Yeah.
So, I mean, you would still encourage her to get it done, right?
Yeah, absolutely,
Okay.
absolutely. I mean, the amount of like 14-year-old bulldogs that I've seen, they're just disgusting. I mean, they could have been fixed a decade ago,
Yeah.
right? So it's sad to see those cases. So yeah, I still encourage it, assuming they don't have any other comorbidities. You know, they have a heart murmur, they have heart disease for other reasons or whatever.
Yeah.
You know, things like that makes anesthesia more dangerous. Otherwise,
I
yeah,
think there
still
could be,
encourage it.
it hasn't been fully worked up to rule out GI and heart stuff, so,
Yeah.
you know, I guess you would normally recommend that.
Yeah, I would.
First, okay.
The GI depends on the history. Right? Is there a history of GI issues or not?
Like it comes in and starts beeping in my
Yeah,
office?
Sure, well, yeah.
So does
that's-
that count?
Yes, that counts.
Okay. Yeah.
Anything up until like intubation
And
versus.
when the stress gets to a certain point, when the blood pressure, and it gets
Yeah.
riled up, that's when it starts
Yeah.
to throw up. Like when it's calm at home, generally it's fine,
Yeah,
but,
yeah, so
Yeah.
blood work, radiographs, ultrasound,
Mhm.
whatever you have available. And then if, oh shoot, I lost
Is
it,
that
there was something else.
the,
Oh, and then working up for cardiovascular also depends. You know, if you don't hear a murmur and arrhythmia and there's no history of like syncope
I'm
or
happy to
whatever.
hear anything,
Then I'm
though.
well, yeah,
Like,
yeah,
you know,
yeah,
so
yeah.
that's why, so like, echo, I
If
guess.
you collect your radiographs and you think that, again, a lot of these dogs have cardiomegaly anyway
Right,
because they're
and
breed,
I remember
but.
in school, like, the cardiologist doing
Yeah.
procedures under fluoro for this particular breed.
There's,
a lot.
I think 2 papers in the proceedings that are incorporated.
Okay.
They're fairly new. They looked at echocardiograms and like, did the patient change cardiac status, and there were changes for the
Okay.
benefit of the patient
Oh, that's cool.
cardiovascularly. All the jargon they use, and like, I don't care, this is boring, it's all the measurements,
Mhm.
but a lot of measurements would improve post brachycephalic surgery.
Okay.
So there is definitely, and core pulmonality is a problem with these patients as well. So this chronic stuff can lead into cardiac disease anyway, long term. It's all gonna come down to what the client wants to afford and where the client, where the
Yeah, I mean,
recommendation
Pumpkin's
are.
pretty good in the sense of, from what I heard, that they cover a lot of this, and she's called them,
Yeah.
but the surgeon had told her, hey, plan for like 2 weeks in oxygen with a feeding tube, like, but where she set her up for like the worst case scenario.
Wow.
Of like, yeah, so that's, you know,
Wow.
because of, she thought of how severe it looked, so I wasn't sure, like, if she was in the right place or not, like, if Red Bank, or where are you from again, you said?
Well, Long Island originally, but I'm in Las Vegas now.
Okay, so do you see or hear of a lot of it being done at like AMC in the city?
Yeah, sir, do you want me for anything? Sorry.
Are you presenting in the next session?
No, I think that's it for
I need to
me.
get my adapter back. from
Yes,
my
sir.
place.
Thank you again.
I'm so sorry.
No, you're good, You want just this part?
Yes, sir.
Okay.
Just leave the rest.
Thank you again, thank
You're
you. So,
Like where, I'm trying to figure out like where you would recommend, you know, if you hear a lot of, you know, if AMC is good or
So
Red Bank.
when I've done, like relief work at like GPs or whatever, and I have a case that has come in and they're stable, but like need brachycephalic surgery, like the suspected does,
Mhm.
I tell them, I say, we can do it here, but I'm going to be, either your dog's gonna go home and we see what happens overnight, which is not ideal, or you can transfer to ER. Or that ER has a specialty center, like the one in Vegas does, then just go there and have them do the surgery. I don't wanna
Right,
deal with
right.
it, right? And it's up to the pet owner, what they can afford, what they wanna do.
Yeah.
So my answer to you would be,
So let's say money's not an object.
yeah, any place that has board certified surgeons,
Right.
has 24-hour care,
Right.
I'm like, go
Yeah,
for it.
yeah, Eclipse has that.
Yeah,
Yeah,
I'm go for it. But just, I'm questioning the whole like 2 weeks in oxygen and the feeding tube.
That's what, this, and then the surgeon, like, the client was like freaked out from her experience talking to the surgeon, so, I reached out to her, and it was the surgeon's day off, and she called me back on my cell on her day off, which I really appreciated. She kind of gave me a slightly different story, but, you know, this is a little difficult of a client in the sense that they didn't really walk into this decision to buy a Frenchie with their eyes open to all of the things, but as many clients do, I'm sure.
Sure.
And now she's just very attached to it, and, you know, it's an emotional decision and she doesn't know what to do, if she could, you know, the possibility of the complications post-operatively killing her dog,
Yeah,
if it,
yeah.
you know, gets aspiration pneumonia, if it, you know, I think, yeah, so.
Well, yeah, I mean, that's the.
I mean,
that's-
so obviously 24-hour care, obviously the board certified surgeon, but I was wondering in amongst them, if there are some who, should I ask about the technique they use
Oh, I see. what
versus
you're
like,
saying.
is it CO2 laser
Oh, I
versus
see.
ligature or they're, you know, it's hard.
It's hard.
Unless you're
because-
working there and you know them personally.
Yeah, because even the literature that's out there, usually it's one study comparing 2 or 3 of these procedures, and then they say, oh, we found this and this and this, and usually it's a combination of pros and cons for each technique, just depends on what you want to do. But none of these studies are extensive, none of them.
Right, like you said.
Yeah, so, and they don't, and it's hard to replicate a study. If you have like one study that compares CO2 and harmonic scalpel and ligature, then the next study will compare ligature to laser, and it's like, well, you know, I can't even compare the 2 studies because they're
Okay.
different. So
Yeah. How many different techniques are there? So I wasn't familiar with the harmonic scalpel.
Yeah, I've never used it before.
Okay.
I just know it from the literature. I have I put this will all be in the.
Yeah, but maybe if I look through your procedure before,
Yeah.
then I'll.
I have to still submit. I just finished them this morning, updating them. So.
I was gonna say, I didn't see them there,
Yeah,
right?
I didn't submit them yet.
Okay.
But like, let's see. I'm looking specifically for elongated palate. That's one that has the most like.
It sounds like you do or you were trained with the ligature and the cut and.
Yeah, the cut, the
Cut and sew?
what do they call it? Yeah, cut and sew. I never heard that before till I saw in the literature, but basically incisional
Okay.
is the one I
Yeah.
was trained on first, and then
Right.
I immediately adopted that ligature once I discovered that. That to me is a no-brainer.
Did you ever try and look at some of the others to see if you wanted to go there, or you were?
No, I
just-
never did. I
Yeah.
never did. Yeah, I've heard great things about harmonic scalpel, because it's been around for a while. But I, you know, you're a creature of habit. It's like,
Right.
oh,
No,
this
no, I
works.
get that. Yeah. Especially.
Okay, so so the excision palatoplasty, which is what we talk about, or staphylectomy, and then there's a folded flap paloplasty. But then as far as how to actually perform the surgery, bipolar sealing device, CO2 laser or diode laser, air plasma device, manual crushing, monopolar electrocautery actually has been listed, harmonic shears, electroscalpel, low temperature, high frequency radiosurgery,
Low
and then-
temperature, high frequency
radio surgery, and then sharp
Fancy.
dissection. Yeah.
Okay.
Yeah.
So.
There's a bunch of different things.
Ligature.
Yeah, ligature is the way I would
Okay.
go about it.
Yeah.
You know.
I felt like part of the
That's what I
room
would
kind of
do.
got a little freaked out when she mentioned the cautery.
Yeah. I wouldn't do. I didn't realize I have it here. I wouldn't do cautery. It just like I said, it just doesn't have the breadth of coagulation that you want compared
Okay.
to ligature. You know. Hell, even like crushing the tissue. So for like partial liver lobectomies, I'll crush the liver first, so that way the vessels are still intact, but the parenchyma is dispersed, and then from there either use stapling device or suture or ligature or whatever.
Mhm.
I prefer even that method, just crushing it to at least
Okay.
get to just cauterizing it. I just can't see it being powerful enough to stop the bleeding.
Oh, yeah, no.
You know, that's all.
I'm not a surgeon, I would,
Oh, yeah,
I could
yeah,
understand
yeah.
that, yeah, that.
No, it's a valid question. She probably
Yeah.
wants to use the
Yeah.
equipment that she has,
Sure,
you know,
no,
available.
yeah, and it's expensive for some places to get,
Yeah,
Alright,
do they?
so
I mean,
I'll look for the proceedings done.
yes,
Okay,
yeah. I'm gonna
like
share
tomorrow
them.
morning or?
Yeah, I hope by tonight.
Okay.
I have to give them to Adam Chrisman. I don't know if you know him.
Oh, okay.
He's-
Yes.
But I have to send it to him, and whenever he can share it with folks, then
And
I will.
think are they
then it'll be.
posting it on the,
That's what I was asking. The woman who did
who introduced
my
you?
moderator. Yeah, she wasn't sure either how they disperse it. I remember.
Just to know that.
I remember one year because they changed around my schedule so much, they ended up emailing everybody my proceedings.
Oh, that's what, yeah.
But I'm
No,
sure
there-
that I'm
there's-
sure
here we
that's
go. So on the
annoying.
app, it says proceedings, lecture notes, and then it says how to. So like, we all get an email with a link to download this app before we come,
Mhm, mhm.
and then it's in there. supposedly.
Okay.
So
So hopefully they just upload it into.
they'll no longer be posted on Flex or as one continuous document instructions. Use your computer to log into the. Yeah, you have to use a laptop, I think, to get to them.
Okay. Yeah, I'm gonna I would just
And
turn
then
it
the
into
hotel
a.
that I was staying at, the internet's down.
Stop.